Okay, so again, pain is carried. Too loud, I think. There we go. Okay, so again, pain starts in the periphery. So we said a good example would be this morning stepping on my son's Hot Wheel truck. Ow! Pain starts bottom of my foot. Information is then carried from that area either by a peripheral nerve or a dermatome segment into the spinal cord to lamina area 1 through 5, primarily lamina area 3, which we call substantia gelatinosa. Okay, now after that happens, then what happens? Okay, so then it goes, so once it synapses here, it then enters what we call the uber of the brain, one of the ubers of the brain, called the spinal thalamic tract. T-H-A-L-A tract. So it enters spinal thalamic tract in the spinal cord, and did somebody just maim themselves? I just heard somebody scream like they injured themselves. Okay, I don't know. Hope not. I pray they're okay. So it enters spinal thalamic tract, where the information is taken from the spine up to where? Good. From spine to the thalamus. Very good. From the spine to the thalamus. Is that the last communication? No. Very good. Where does it go after that? Thalamus to somatosensory cortex of the brain. Very good. That's how pain is transmitted. So it starts in the periphery and then carried to the spinal cord. This would be called our first order neuron communication. From the periphery to substantia gelatinosa. Our first order neuron communication. This is the first set of communication regarding this area. And so on the slide here, you'll see that it even says first order neuron. So that's where the information is being picked up from the periphery to then be synapsed in the spinal cord in lamina area 1 through 5, specifically lamina area 3. So that's our first order neuron communication. It's the first level of communication. Let me make sure that is in focus there. Yep, let me zoom out a little. Oh, crap. Okay. And then focus. No bad focus. There we go. Okay. Okay, so this is our first order neuron communication, which it even says there. First order neuron from the periphery into the spinal cord. Our second order neuron communication is here. When it enters the spinal thalamic tract. once it enters the spinothalamic tract, it does something really interesting. It's going to cross to the opposite side of the spinal cord. So it doesn't stay on the same side that the information is brought into. That's really the cool thing. So once we get to Therex 2 and we start talking about spinal cord injuries, and we'll talk about how you lose pain and temperature on one side and you may lose motor on the other side, it'll start to make sense because where things cross. Some things will cross in the spinal cord, some things will cross in the brain. But the second order neuron here crosses in the spinal cord. That makes it really interesting in general. So it crosses to the opposite side of the spinal cord once it enters. So it's going to cross to the opposite side of the spinal cord and then go up to the thalamus. So it crosses in the spinal cord, then ascends or travels up to the thalamus. And then our third order neuron communication is just this one here. From the thalamus up to the somatosensory cortex. And it has to get there because that's where we plan an action to respond to the pain. So the somatosensory cortex will then talk to the motor cortex and tell it what needs to happen. In the case of me stepping on the Hot Wheel and it hurt my foot, the brain told me, lift your foot quickly, dummy. Ow, ow, ow. And then yell at your kid, pick your darn Hot Wheel trucks up so I won't step on them all the time. It didn't tell me to do that, but it just made sense to just yell at somebody. He was there. It was his truck, so I had to fuss at somebody. Never blame yourself. It's always the kid's fault. So, yeah. So the motor cortex plans the response. So I have to get it to the somatosensory cortex because it is the one that's responsible for talking to the motor cortex in planning a response. Okay, so now that makes sense. We understand pain, how it's communicated. Great. Now, let's talk about how we mitigate it or how we treat it therapeutically. So there are two ways that we talk about treating pain. We said one way we can treat it is through sensory analgesia. Sensory analgesia. That works one way. And then the other way we said we can treat it is through endogenous opiate release. Okay? So we're either doing sensory analgesia or endogenous opiate release. Or I wouldn't call it, let's change that. Because the goal is to produce sensory analgesia. Let's call it gate, GAT control theory. The goal is to produce sensory analgesia, and the goal is to liberate endogenous opiates. Okay, so let's talk about where each system works, because that's really the key to understanding how we treat pain. Honestly, once you know where the systems work, then you'll know how they're effective. So with gate control theory, it was developed in the 1960s. Who were the people responsible for developing it? Melzick and Wall, cool names. Okay, so Melzack and Wall figured out something very cool. They figured out which cells in the periphery are responsible for communicating pain to a dermatome or a peripheral nerve. So they figured out which cells are responsible for communicating information from the periphery to a dermatome or a peripheral nerve, or which cell types carry pain from the periphery up through the peripheral nerve into the spinal cord. Think of it that way. So there are specific cell types that carry pain information from the periphery to the spinal cord. It's traveling up through a certain type of cell. They found out that C fibers and A delta are cell types that carry pain from the periphery into the spinal cord. Now, each cell type carries a different type of pain. C fiber carries what type of pain? Dull, like achy. I don't know if that's spelled right, but achy. A delta carries sharp, fast pain. So, one's dull, achy, one's sharp, fast. But both are essential. So dull and achy is carried by C fiber. Why? What type of cell are C fibers? Unmyelinated. They're small, unmyelinated. Okay. What about A delta? Small, myelinated. So they're going to travel faster. Myelin sheath makes things travels faster through, what's the name of that? It's the jumping. It's going to come to my head. Nose of Ranvier. So you remember that from A&P 1 and 2? Some people nodding, some people like I need Jesus to help me with this one. Okay, so myelin is a fiber type that insulate nerves. So it's an insulin sheath around nerves. And the sheath allows for nerves to communicate faster. So instead of having to stop at every axon terminal, so the dendrite goes to the axon terminal, dendrite, axon, terminal, dendrite, axon, terminal, which is really slow. Myelin allows for me to jump different areas. So instead of stopping at every one, I'm able to jump 5 or 6 areas to communicate things faster. So essentially, it is the skill of having to stop at every location or just stopping at one location and doing everything. So it communicates faster. It's called nose of Ranvier. So that's the way it communicates faster. Not important for this. Just know that's how that works. So A delta is going to be small, myelinated, so it communicates faster. C fiber is small, unmyelinated. So Melzack and Wall hacked the system. They found a third type of cell called A beta. What type of cell are A betas? Large myelinated. Large myelinated cells. So they're different from these types of cells. What type of information do they carry? Vibration, Itch, tingle. It's a type of, it's like a discriminative touch. Or, what is it? Is it discriminative or gross touch? But we'll just call it touch for right now. Yeah. So it carries that information. So what they figured out is if we can introduce information in the periphery where we were feeling pain, and we can stimulate these types of sensations, vibratory, itch, tickle, tingling sensation, if we can stimulate those, then what we can do is we can rush A beta cells to the spinal cord and cut off the information that's being received at lamina area 1 through 5 and lamina area 3. So gate control theory works here. Its job is to stop, or its job is to rush A beta into, is trying to rush so much sensation of A beta into the spinal cord that it turns off the abilities to sense C fiber and A delta. So we're trying to rush those sensations into the spinal cord so that we no longer feel A delta and C fiber. So it works at the level of the spinal cord. We're trying to rush so much A beta that it closes the gate on C fiber and A delta. Literally. Like we're trying to close a gate. So it wants to send these sensations to our brain, tell our brain to feel this stuff and not this, and hopefully after we're done with a treatment session, it will turn off for a short period of time our brain's sensation of pain in an area. It decreases it. It gives us analgesia, where we're lowering the pain number. So the goal is to hopefully block it, and if we can block it long enough, then we perform other things. So that's why modality's job isn't to fix it. The modality's job is to block it, so then we can do what we need to do with therapeutic intervention to help turn it off. So yeah, so we're trying to block it, or we're trying to do something else, which we'll talk about in a second. But for gate control, we're trying to block it long enough that it turns off enough that we can then do other interventions to help turn it off for good. So this doesn't fix pain, it treats it long enough so that we can perform functional activities that hopefully turns it off. Make sense? Everybody? Good stuff. So this is where Melzack and Wall's theory comes in for gate control theory. It's trying to block these fibers from synapsing on lamina area 3. It's trying to block it, close the gate on it. It's rushing in and literally trying to slam the gate behind it so that those fibers don't do their job. Endogenous opiates works at this level, down here. After information has synapsed, after the E-Stim information has synapsed in the primary somatosensory cortex, it then communicates with the primary motor cortex, and it tells it to do something. And the thing that endogenous opiates tells it to do is, the thing that setting tells it to do is release these endogenous opiates from different areas of the body so that it can treat pain through the same way medicine does. It produces an analgesia in the system. So just like I would pop a pill to try to cure pain, and its job is to release I take these opiates by mouth, and its job is to chemically treat pain the same way medicine chemically treats pain. I can chemically treat pain internally through releasing these pain reducing opiates that are naturally produced in me. There are different ones. I can have endorphins, I can have enkephalins, I can have serotonin, I can have dopamine released. All of these things have the potential to be released. The two primary ones that are released through this is endorphins and enkephalins. That's okay. And they have the ability to, just like a drug, they treat pain systemically. So these endogenous opiates are released into my system and they treat pain systemically. They're not just blocking pain, they're releasing chemical messengers that actually treat pain inside out. Okay. So that's how pain is communicated, and those are the ways that we are trying to produce pain reduction. We're either trying to block pain from getting its synapse on lamina area 1 through 5, specifically lamina area 3, or we're trying to send a relaxing sensation to the brain and force it to then release chemical messengers in the form of endogenous opiates so that it treats the pain systemically. Okay? Anybody lost? Make sense? Good. Way to go. That was a smart class. Way to go. Okay. So now that we know this is the goal, so now when we're treating, I'll leave that up. When we're treating, we have different waveforms or different, let's say this, let's start with this. When we're doing this, knowing this, we have different protocol setups for our E-Stim unit to produce these. So it can't be set the same way to get the same results for both of these. The protocol is going to be different based on what am I trying to do. Okay? So the protocol is different based on what I'm trying to do. If I am trying to do gate control theory, I'm trying to produce what's called sensory analgesia. Sensory analgesia. Trying to lower the pain number, trying to decrease the sensory response and produce analgesia, lowering my sensitivity to it. When I'm doing sensory analgesia, I need to produce the tingling sensation that's going to block the impulses, so I need to stimulate A beta. So my goal is to stimulate A beta when I am trying to do sensory analgesia. So I want a strong tingling sensation, but I want no motor response. So I want it strong but not uncomfortable, but I don't want motor. I want it to just be sensory. It needs to be strong enough to be sensory and not produce a motor response. So when I'm doing sensory analgesia, I want a strong motor response, strong sensory response, stimulating A beta, vibration and tingling. Those are two of the sensations that I feel from the E-Stim unit. We agree? If you put it on, you go, ooh, it feels like it's vibrating. Ooh, it feels like it's tingling, prickling, those things. That's good. That's A beta, picking that information up. So I'm trying to stimulate A beta, strong but no motor. I can either do it to surround the pain. We've done that several times. Today we'll show you how to do cutaneous distributions, and we will set up for dermatome. We may set them up and turn them on. We'll see. We'll look at it. But for sure we'll show you how to set it up. So when I am doing that, I can surround the pain site. So if I know if it's over a specific muscle, let's say it's over upper trap region or levator scap region, if it's over my hamstring region, if it's over gluteus region, lumbar spine, wherever the pain is, I can do it over the painful area. I also can do it over a dermatome or over a cutaneous distribution. So those are the major ones. When I'm doing sensory analgesia, my protocol is I'm trying to produce strong stimulation of A beta. So I want really high frequency, somewhere between 50 and 150 pulses per second, or hertz, depending on which waveform I use. But I want a low pulse width if I'm using a pulsed current, because the longer my pulse width, the greater the chances that I'm going to zoom past A beta and go right to a motor nerve. So longer pulse widths are responsible for stimulating motor nerves or further. That's what the strength duration curve tells us. So I want shorter pulse width if I'm using a pulse current, longer frequencies if I'm using a pulse current. If my objective is to release endogenous opiates, I want the exact opposite. I want lower frequency, but a higher pulse duration, or a higher phase duration, a pulse width or phase duration. Good question. That's what we're going to get into just a minute here. Good question. What are they used for? Okay. So, when I am doing that, yes. So when I am trying to release endogenous opiate, I'm going to use lower frequencies, and I'm going to use longer pulse widths or longer phase durations. Okay. Usually, if I'm trying to liberate endogenous opiates, then I'm trying to do it through very specific places relating to the skin. I'm either going to try to use motor points, which are areas where the peripheral nerve enters the muscle, or I'm going to try to use trigger points, which are areas of raised muscle tissue or muscle fibers that are either active or dormant. Active ones are going to refer pain from the area into other places. Those are dormant, are usually just knots in the muscle, but they don't refer pain. They're painful, but they don't refer pain. Trigger points. They're all over the body. Showed you those. Or I can use acupuncture points, which overlies a lot of the times a lot of places where you're going to have trigger points. Okay. Let's see here. Trying to find this page. If you'll flip to page 422 in your book, you'll see a very cool picture there. 422. In it, you'll see a picture that looks like this, and it has either, so the key on that, some are acupuncture points, some are trigger points, and all of them are, some are combined. So the triangle is one, and then the actual down pointing arrow is another. So the key is on 421, and you'll see a lot of times acupuncture points overlie trigger point areas. So where you're seeing the square with the triangle in it, those are combined points. So really, depending on what you're hitting, you're probably hitting both sides. Okay. Any questions there? So far, so good. Okay. So, I hadn't forgotten your question, Quanta. I'm going to get to it, I promise you. Okay, so that now leads us, we understand how pain is transmitted. We understand what our two objectives are when we're trying to block pain or release endogenous opiates. We understand where we're trying to hit. If we're trying to hit sensory analgesia, we're either surrounding it or we're going to do dermatome segments or peripheral nerve or over the peripheral nerve. We'll show you those in lab. If I'm doing endogenous opiate release, I'm trying to do it either through a motor point, a trigger point, or an acupuncture point. Okay? Now, the last thing we need to do, we understand the protocol, we understand our frequency, we understand our phase durations or our pulse widths. Now, the only thing we need to do is what? Treat it. I agree. How do we treat it? I agree. Keep going. Shovel still too shallow. Dig a little deeper. Yes, say it louder. Thank you. I need to pick a treatment mechanism. How am I going to treat it? Yeah, we know we're going to do STIM, but what am I going to do? Because everything is not functional for every use. So now when we talk about how now, brown cow? How? So if I am trying to do gate control theory, if I am going to pick a current of use, what are currents that I can use to treat for gate control theory? Meaning it needs to be something that allows me to set a frequency and something that allows for me to produce sensory analgesia without motor response. So what are some currents or some waveform types that we can use to treat gate control theory? Okay, I agree we can use AC current. Specifics? We can use IFC, I agree. Anything else? I wouldn't use Russian. Russian is not for pain. I can use pre-mod. I 100% agree. Okay. What is the difference between IFC and Russian, even though they're both AC waveforms? IFC uses true quadrupolar. I agree. It uses true quadrupolar. So that means it's going to be 2 channels with 4 electrodes, and it's all going to bear the same setting. So when I turn up one channel, the same thing happens to the second channel. So IFC is a treatment protocol that uses high frequency. So it is a medium to high frequency waveform. So usually 4,000 hertz is our carrying frequency. So that's going to be our base frequency. And then we will have our treatment frequency, which will be whatever the frequency we set minus a second base frequency. And that sets us up for what we actually will feel underneath the skin. So the patients don't feel the 4,000 hertz, they're just feeling the treatment frequency that we set. So that is IFC, true quadrupolar. Set up, so that means it's going to be crossed. So our electrodes will be crossed in the area, and its job is to treat the center line of the area. Okay, what about pre-mod? What is pre-mod? So it can be, yep. So we can use it as a dual biphasic. We can use it in a monophase. So I can have one electrode in the area, one electrode out of the area. I can use it as a biphasic, or not biphasic, a bipolar. I said monophase, monopolar. Sorry. Which is one electrode in the area and a dispersive out of the area. I can use it as a bipolar setup, which is two electrodes in the area. I can use it in dual bipolar, where I now use two channels, 4 electrodes in a large area. So it has multiple ways I can set up pre-mod. Whereas IFC, I'm limited. I can only set it up as true quadrupolar, 4 electrodes crossed. So I can use, with pre-mod, I can use, like I say, monopolar. So let's say I have lateral epicondylitis pulling on my lateral epicondyle. I find a trigger point right here, which I actually have. I can do monopolar, put an electrode there, put one on my back where there's not a lot of muscle tissue, and I can treat monopolar. Let's say I have, I shouldn't say treat. I have pain in my upper trap. I can put an electrode here on the origin, put one near the insertion, and I can treat using that with a bipolar setup using pre-mod. If I want to do it across my hamstring, because I have some hamstring tightness or soreness or pain in my hamstring, I can use dual bipolar, set it up where I have 4 electrodes that cover the area. So it can be used in a number of different ways. Whereas true IFC is true quadrupolar. Has to be 4 electrodes, has to be crossed. Okay? Pre-mod is different from IFC in that where IFC does the high frequency coming out of the channels on the actual patient, pre-mod does its high frequency in the machine. So it's still a high frequency waveform AC current, but it does its high frequency components in the machine. IFC does them on the patient. Okay. Oh, I thought you were like, you're fine. Okay. Are there any other waveforms I can use for gate control theory so far? I agree we can use AC. Anything else? Hubba lubba lubba. Pulse currents. I agree we can use pulse currents. Okay. Which pulse currents? I wouldn't use a high volt for gate control because it uses a spiked wave and it wouldn't be really comfortable for patients to endure that trying to produce sensory analgesia. When you get it up really high frequency, it becomes really bitey and uncomfortable. So I wouldn't use high volt for gate control. What are some other ones? Symmetrical biphasic. I like that one. Sim bi. Okay. Symmetrical biphasic. It's just like pre-mod. It can be set up as a monopolar, a bipolar, or a dual bipolar. It's multifaceted. So I just put a MBDB, monopolar, bipolar, dual bipolar. So it is a good pulse current to use. If I'm using symmetrical biphasic, which muscle types would I be more inclined to use it on? Larger muscles. Very good. Very good. Shown to be a little bit more comfortable for larger muscles. It's not limited to that. You can try it on anything. Any other pulse currents I may want to use? Very good. E-Stim biphasic. Asymmetrical biphasic. Good for probably smaller muscles, and it's the same way. It can be set up as monopolar, bipolar, or dual bipolar. So it functions in a multitude of ways as well. Okay. Good. So those are waveforms I can use to treat gate control theory for pain control. I can use pulse currents, which are, that's what you have there on the table. Those are pulse current, those small units. Or I can use pulse currents from a big unit. I can use AC waveforms. I can use IFC or pre-mod, either way. All of them work. What about if I wanted to treat for endogenous opiate release? All right. What type of current is high volt? So I can use a pulsed current. I can use high volt. Okay. I agree. Can. It has the abilities to be mobilized into a current type that can be used. High volt has the ability, and all of these have the ability to have low frequencies. That's the major thing you need for endogenous opiate release. It has to have the abilities to have low frequency. Because remember, your frequency goes from 50 to 150 gate control all the way down to 1 to 10 with endogenous opiate release. My protocol mandates it's somewhere between 1 to 10 for my frequency. So the waveform has to be able to accommodate that. Any other currents, any other waveforms, pulsed? Sure, E-Stim biphasic, yeah. Very good. All three can be used for endogenous opiate release. I agree. All three are liable to be used for endogenous opiate release. Any other currents or waveforms? No. We're going to show you what we use Russian for this afternoon. Russian has a very specific setup. Any other ones? Hmm? Could we use an AC current? Good question. What do y'all think? Can we use an AC current? Which AC current? What are our choices? There's one more pulsed, and it's probably not found on but one machine, but it's VMS also, variable muscle stimulator. You can use it for a pulse current for endogenous opiate release. Not really comfortable, but you can use it. So, for AC currents, can we use them? Anybody? Somebody? No? You say no? Why do you say no, sir? I'm so proud. Feel like I've done my job somewhere. Somebody listen. Tear almost came out of my eye there. Say that one more time for me, sir. The frequencies do not go low enough to use AC currents to treat with endogenous opiates. Yeah. Absolutely. Absolutely. Very good. So for the most part, I'm going to be using pulsatile currents if I want to release endogenous opiates. So a lot of people, when you get to a clinical situation and they're saying, oh, I've had E-Stim before, I've done it, I didn't like it. Most of the time, what they have had are the old square machines, my favorite baby, that only offers primarily AC waveforms. Because it offers IFC, it offers pre-mod, it offers Russian. So most of them have never tried this form of E-Stim. So that's why it's so important to ask the patient, what were they trying to do? And even if they've had gate control theory, most of them still haven't had it pushed to the level where it produces true sensory analgesia. And it's not till you get to that level that we're actually stimulating A beta high enough that it's blocking C fiber in A delta. Does that make sense? So I can do STEM and still not do it to its optimal level. Not that it's wrong, it's just not optimal. So we want to do optimal. Everything we do want to be optimal. Highest extent. Greatest skill we can do it with. Okay? Questions? So this walks us literally all the way through pain. This is it. This is everything you need to know about pain. How it communicates, what are our treatment options, how do we treat it, where we treat it, what we're doing is everything. It's pain. Okay. Take 5. We'll pick up on page 406 in chapter 14 again to finish this chapter out. We may pick up on 40 somewhere. I'll let you know. Yeah, 406. Probably 403. I like the chart. Mm-hmm. So pulse currents frequencies usually range between 1 up to about 2. You can get higher frequency. It's usually somewhere between 1 and about 500 for frequency for pulse currents. Symmetrical, biphasic, asymmetrical. So their frequency is going to be between 1 and 500. No, not 500. Probably 1 and it may get up to 300. So it'll have a frequency as low as 1 and about 250 to 300 for frequency. And that's still not fair to say it that way. So think of it, okay, let me say it this way. So the way pulse current works is its job is to use pulse width, or it's going to use pulse width of a waveform so that it can then penetrate the skin. So it uses pulse width, usually between 1, it gets as low as down to 10 to 15, and it gets up to 500. With AC currents, they're going to use high frequencies to penetrate the skin. So when I say it's done in the machine, it's literally mixing the way it's creating that high frequency current from the machine, and then it's delivered to the body in the frequency that we set. So the machine is the one processing the high frequency versus IFC is done not in the machine, it's done on the person. So one will have a high frequency waveform like 4,000, and one channel will have one that's like 35 or 3,850. And you put the two together and they create an interference waveform, and that's what the patient feels. So IFC does it on the person, whereas pre-mod does it literally all of that with the frequency mixing, so that what the patient feels is the frequency we set. It's done from the machine itself. So we don't have to use 2 channels or 4 electrodes to get the same benefit. Does that make sense? I feel like I'm confusing you more. Essentially, the machine does what it takes us 2 channels to do with IFC. Let's give a synopsis of it. Smarter, still lost, hopefully, kind of, sort of. Yeah. Essentially, the machine is doing the work of what it takes us 2 channels and 4 electrodes to do with IFC. So that's a good way of thinking about it. I hope you're not lost. If so, see me. We'll work it out. Good question. Why do we use IFC over pre-mod? What do we say IFC is really good for? Agree, but there we go. Larger muscle areas or larger areas where I'm trying to get a deeper penetration, because it goes, so the higher frequency goes deeper into tissues. So if I'm choosing IFC, I'm usually using it over a larger treatment area or over an area where I'm trying to get deeper in the tissue. Yeah, you can use any of the other ones, just depending on what you're doing it for. Mm-hmm. Or you can use pre-mod. So IFC is good for, like I say, large areas or areas where you're trying to get deeper into the tissue. Those are its true benefits over the other waveform types. So it's high frequency, and it's better for larger areas or to go deeper into tissues? Good question. Any other question? Yes, sir?
So if you use an IFC, say, instead of getting where you want it to be, what if you use a deeper, deeper frequency on a different part that wasn't supposed to be hit? Does that cause any damage by doing that? Or
Give me,
that's why you, like,
give me clarity.
so like, say you're trying to use it on, say, the back.
Okay?
You want, if you have a specific point you want to get into the direction, I guess that would be not the deep patterns or whatever it is. So the exact middle, where the deepest frequency is. So if you were to misalign it and put it, say, somewhere else where the frequency was deeper but not where you wanted it, like healthy tissue, would that cause the issues there or just?
No, because it still won't get deeper than the layer of muscle. So it's not going to penetrate down and start conducting through bone or things like that. It's going to stay pretty surface level. What we're doing when we're using TINs or transcutaneous, it doesn't have the abilities to penetrate extremely deep and cause damage in other tissues. So if anything, it'll cause damage to the superficial skin, but IFC shouldn't even do that. So only direct current or currents that have, or waveforms that have polarity makes us nervous about that. So no, it would never damage underlying tissue. Should not. Yeah, still really superficial, because by the time you pass through your resistors in series, which is your skin and your adipose tissue, and then you get to your resistor in parallel, you've gone through enough tissue where you're kind of really lowering whatever current is being penetrated. So you're either going to stimulate a nerve or really just a nerve. You're not going to get down blood vessel level or bone or anything like that. It's not that deep. Good questions. Any other questions? I like questions. Okay. So this is the chart you see on page 403. I like it. Let's breeze through it real quick. So it talks about my patient is having pain of some sort. So it's a treatment chart to let you know should or should not use E-Stim. So if my patient is not having pain, then there's no reason for me to do a pain modality. So if the patient walks in, how are you feeling today? I'm a 0 out of 10, I feel great. All righty, so we're gonna start right off on something else. We're gonna do some kind of warm up, active, put you on an arm bike, or we're gonna put you on a bicycle, an elliptical, we're gonna do something active. Oh no, why can't we start with the tingling thing that we used to do before? You don't have pain. Pain is absent. There's no reason for us to still be doing a pain treatment modality and you don't have pain. So you have to help your patient see this. Even though it feels good, there is not a need for it. And I can't be billing for something that is not a necessity or that's called fraud. Get put in jail for that. So there's a point where I no longer need modalities. That's the whole goal. Usually early on in the treatment, depending on what's going on with the patient, I'm usually moderate with modalities, very light on therapeutic intervention, trying to get pain down. As we continue to work, I start to decrease my modalities and become more dependent on therapeutic exercise or active activities, trying to get them functional. So that's the goal. If it's absent, we don't need it. If it's present, then I need to move to past medical history or the history of the present condition. And whatever the source of the pain was. Based on these two results, if I find in their past medical history or on the exam something that's going on and it's a contraindication, then I don't even use E-Stim. So if you find a contraindication, don't touch them with E-Stim. If they have a pacemaker, if they have active cancer in the area, they have something crazy going on, it's a contraindication. It's a no. If it's a no, or if it's a precaution, even if it's yes or no, then I'm able to move forward. So I'm going to monitor this patient if they have a precaution and it's a yes. Now, I need to know what's the duration of the symptoms. If it's acute, then I'm probably going to use more sensory analgesia for patient treatment. So sensory analgesia, by research, has been shown to be a more preferable or a better type of treatment for reducing acute pain lasting less than 3 months. So if it's acute, sensory analgesia is the protocol you want to go with. If it is chronic in nature, then I want to use the endogenous opiate protocol. Here is great relevant information. If the patient has trigger points, they are chronic. Doesn't matter, even if they just noticed them when you touch them. Oh, I just noticed I had that. It's a chronic problem. You don't develop a trigger point in a day or less than 3 months. Those are called hematomas. So if it's a trigger point, it's a chronic problem. So all trigger points are chronic problems. Even if they go, well, it just kind of started to get worse in the last couple of weeks. It just means it may be now more active than it was before. But if you find one in the tissue, it's a chronic problem. Endogenous opiate. So then I need to know, was my treatment effective? If yes, continue till my goal is met. If no, then I start to change the parameters, use different methods, maybe choose a different waveform. I change up what I'm doing so that I can become effective with my patient. If I thought the problem was acute and maybe it was chronic in nature, change up how I'm doing it. So don't be afraid to change stuff. You're only limited by your knowledge and your creativity. It's a great skill. Okay, any questions there? Okay, page 406. Under treatment expectations, it walks us through the healing of things. I know you guys have already done that once. We're not going to repeat that. I want to start on 406 on the right-hand side of the page where it says the purpose of E-Stim. So it's the actual second paragraph there. The first one is the continuation. You got the real first paragraph, second first paragraph. It says the purpose of E-Stim during a normal course of healing of an acute injury is a transition from managing pain at rest to post-treatment pain reduction. So those are things that we're trying to either do. Manage pain at rest or post-treatment pain reduction. So we've done some things, we've stretched something out, and we've made them really uncomfortable, really sore. We can do it after treatment, or if they walked in sore and hurting, we can do it before we do treatment. Either way. Each patient's response will vary. Therefore, our goals should be formulated and to be individualized and adjusted accordingly. Okay. Individuals with chronic pain conditions may also benefit. The expectation of eliminating pain symptoms may be unrealistic for a lot of patients. Thus, the goal here is to help to control pain and allow for better function. Because remember, we're doing endogenous opiate release. We're trying to, it's just like medicine, it's a systemic thing. So eventually that's going to wear off. So we still need to be doing therapeutic interventions that even after it wears off, the patient will still feel better overall. Okay. Down at the bottom, the treatment goals for E-Stim with chronic pain may emphasize functional ability while keeping pain symptoms at a manageable level. The goal may be an effective reduction in pain that allows for the patient to either walk for longer periods of time, provide comfort so that they can do work-related tasks. They should also be able to use home units to manage their symptoms as well. If they're getting great success with units that you're using there, remember, battery power units are just as good based on the research as corded units. Corded units are a little bit stronger, I know, but they both can do the same thing if programmed correctly. Okay. Complete treatment of chronic pain is multifaceted. Developing relaxation skills, coping skill, increasing flexibility, strength, and endurance will enhance a patient's recovery. Those are the therapeutic intervention things we want to be doing. So we don't want to just E-Stim them to death and high-five them and send them home. That's not enough. We want to be doing these other type things. Increasing flexibility, strength, and endurance, talking to them about relaxation skills, coping skills, trying to help the best we can. Okay? Any questions, comments, or concerns? All righty. So we will. This